able to trickle in. Thank you for being in, everybody. All right, welcome everyone to this Renegade Research webinar. If this is your first time with us, thank you for joining us. I am Isabel, CEO of our organization. We are a patient and caregiver-led, decentralized 501c3 nonprofit organization focusing on complex multi-system chronic conditions such as ME/CFS and long COVID. Within this, we have 3 areas of focus: research that is agile and patient-centered, coaching and telehealth to provide care support, and education to increase the number of clinicians treating us. Our work is made possible by our wonderful team of volunteers who move the wheels of our organization. Most of us have a personal interest in advancing research and care of these conditions. To stay in touch with us and hear about upcoming events, please subscribe to our newsletter and follow us on social media. We will be posting those links for you throughout the webinar. As a nonprofit, our work also depends on donations of all sizes. You can help fund our work by donating to our funding campaign and also by sharing our campaign with others who can donate. To raise funds, we also have some affiliate discounts by partnering with companies whose products and services we have used and like. This does not constitute advice on using those products and services, and as always, discuss with your healthcare team if you do choose to use them. And if you do so, please consider using our discount codes to help fund our nonprofit work. Today's webinar is an open discussion with the panelists that you see here, and we will be taking lots of questions as well. We are discussing the nuances of PEM, post-exertional symptom exacerbation, and also crashes, how patients define it, and how we can better communicate with clinicians to improve quality of care. And when you guys speak, if you can do just a really quick introduction of who you are, and we'll get started by having Dr. Yellman talk to us a little bit how he approaches PEM and the different aspects with his patients.
Hello, everybody. I'm Dr. Braden Yellman. I have been in the space of ME/CFS and long COVID now for over 8 years. Before that, I was practicing rheumatology and still practice rheumatology, but full-time kind of on ME/CFS and long COVID at this point. And I'm happy to be here today. I've been thinking about PEM for a very, very long time because I think it is, as we all know, the kind of core defining or what we call pathognomonic feature of something that is ME/CFS or long COVID related. And certainly people can present with a lot of symptoms of that illness, but they often will sit on this edge. And when they pass that edge and start experiencing PEM, we think of the confluence of all of those illnesses and those comorbidities together a little differently at that point. And so I would probably just start by saying that I think of PEM as a separate physiological state for people. There are all kinds of ways in which people can experience exacerbation of the symptoms that they have as part of this illness, but post-exertional malaise is not just exacerbation of those existing symptoms. It is a truly different physiological state in which the body is not functioning the same, even as it is at baseline illness.
What do you see are the challenges in understanding patients' explanations and different attributions to how these states are described? So whether it is, PEM as you understand it as a clinician, or whether it is an exertion intolerance or symptom exacerbation, or how patients defined, a crash, which can vary, so great between patients.
Yeah, we've had a lot of discussions about this, from the work perspective behind the scenes, really trying to think about how to define post-exertional malaise, not so much because we have a magic bullet for the symptom, but because it's really important to identify from a research perspective so that we better understand how to ultimately treat this illness better, maybe even end up with a cure there. And I think you're alluding to something that's really difficult about post-exertional malaise. There's several factors there. One is it's individualized, right? There are common features, but everybody's presentation is just a little bit different. So you can't just put people into a box with that. And the second feature is that it occurs as a result of exertion, as we think of it. And that exertion identifying that exertion can be really difficult for patients until they really get familiar with their illness or until they've had some time to learn from other patients or from clinicians. And the reason for that is multitudes. One is that there's often a delay between what somebody does that we would consider exertion and then the actual onset of this new physiological state that we call post-exertional malaise. And I should amend that statement, not often, always, right? You can have exacerbation of other symptoms that happen immediately, but we wouldn't necessarily consider that this altered physiological state of post-exertional malaise. Some people, it's really easy to still say, I did something one day, 12 hours later, I feel much worse. It's easily identifiable. Other times it can be up to 72 hours later. It can be just a bunch of little things adding up, so it's hard to know what tips the scale. And then when you're in post-exertional malaise, if you continue to experience even mild amounts of exertion and you have a low threshold for entering post-exertional malaise, you can stay in it or sort of a rolling state of post-exertional malaise for a long time, also making it really difficult to say, what are my baseline days and what are my sick days? And then I think thirdly, like we were alluding to before, you can have symptom exacerbation that occurs immediately with certain comorbid illnesses. So, for example, I, as an individual, experience POTS, postural orthostatic tachycardia syndrome, but I do not have ME/CFS and I do not experience post-exertional malaise. And yet, if I go outside today here in Utah, it's about 100 degrees out. If I tried to mow the lawn like I would 10 years ago in this kind of heat, I will start feeling really sick. I will have to lay down. I will have tachycardia and fast heart rate. I'll start getting sweaty. I start vasodilating and feeling nauseated. These are symptoms of an underlying dysautonomia that I experience. But the next day, I don't have a new physiological state where my baseline status is reduced. So I have symptom exacerbation, but not necessarily post-exertional malaise. And so trying to ask people about their crashes and their symptom exacerbation is how we've generally, I think, approached asking about post-exertional malaise in this field. And sometimes I think we don't always capture all the details if we don't spend enough time coaching people on sort of recognizing those differences. And it is not easy. I mean, I know people who are very intelligent who I've worked with for several years before they finally sort of understand where their thresholds are and what pushes them into post-exertional malaise. The last thing I forgot to mention too is that exertion as a term can be a little misleading in and of itself. It doesn't necessarily have to mean exercise or even physical exertion. That exertion can be cognitive. That exertion can be emotional, right? That's not necessarily something we think of as, hard cognitive work. And yet on an energetic level, having emotions really can tax the mitochondria, for example. And that can be good and bad emotions. It doesn't have to just be everything is symptomatic and things aren't going well for me. It can be Christmas morning, opening a present and being excited, or seeing someone you haven't seen for a long time. When people are isolated with ME/CFS and they finally feel well enough to see a friend, was it the fact that you sat up and talked to the friend for 20 minutes, or was it the excitement before and after and the human emotion of that actually contributed to post-exertional malaise? So it can get very challenging to think about, and there's no, I think, one definitive way to measure it.
How do that differentiation, once that understanding is established, with the care that you're giving the patients, how does that differentiation contribute or changes to the way that the condition itself is managed as a whole, aside from pacing?
Yeah, I mean, I think from my clinical perspective, sitting in the seat of a provider, when you see somebody longitudinally over time and they come back and they have new symptoms, or we've attempted a certain type of therapy, whether that's a pharmacotherapy or a surgical intervention or a particular just change in behavior, um, there are a lot of times where that doesn't always go to plan, right? I think all of us know that it doesn't always go perfectly. Even when we know things work across populations, it may not work for one individual. And so the question almost always in these clinical visits is what's going on and what's contributing to why this didn't work for someone. And very often I often say that if we try something and it doesn't work for an individual, instead of putting that tool in the garbage bin and setting it on fire, we put it back into the tool belt, right? And then maybe we come back to that tool later, a year later, 6 months later, when we've tweaked some other aspects of the illness, and improved whatever was getting in the way of that. And there's a lot of things that can get in the way of our tools working. Post-exertional malaise is certainly one of the top ones, right? And I would say if I have attempted a new therapy with somebody and they're not necessarily responding, or they have an adverse reaction, there's a lot of reasons for that, but one of them that we have to screen for is post-exertional malaise. I feel very strongly that most therapies, there are certain things that can help in PEM, but most therapies are just not going to work at that baseline physiology of PEM in the way that they might work, even though you're still sick with ME/CFS, at your baseline function. And so if you're trying to determine why is something not working or what is going on with any individual's physiology that is interfering with progress, understanding whether they're in PEM, how they get there, how long they've been, whether they're moving in and out, helping people stay in that threshold can really make a difference. And the other thing I think is really important to point out, if we did nothing, we put nothing on the table as far as pharmacotherapy or other interventions. If you ask someone if they're capable of doing so to avoid post-exertional malaise, to maybe go above and beyond to really limit one's activity for a while and avoid post-exertional malaise for, say, a month, you actually see that people's baseline starts to shift. And it's different for different people, right? It can be longer than a month or less than a month. It depends on the severity of the illness. But for the purposes of this example, if you can go a certain amount of time without post-exertional malaise, that seems to raise one's threshold a little bit against post-exertional malaise in the future. And so a lot of times in approaching the long-term care for people is we try to give them tools that make it easier and easier to identify PEM and still live a degree of their lives without crossing over into that threshold, so that they can come back to me and say, it's been 3 months since I've had post-exertional malaise. And almost universally at that time, you can actually push the limits of what used to be that threshold and maybe go a little farther without experiencing PEM. Now, we're not saying we want to have people push too hard and then end back up in PEM. But the longer you go without it, it seems the greater chance you can then go without it. And conversely, if you keep entering post-exertional malaise because you've got to take care of your family or you got to stay employed or, whatever the reason is, and they're very legitimate reasons, it doesn't matter. If you keep entering post-exertional malaise several times per week, it seems like that threshold gets worse and worse. And I think that's what people often describe as their baseline getting worse. I think they're actually experiencing a lower threshold for entering PEM, or less spoons, as we often would talk about in the patient community.
Is there a way to really differentiate between those two? Because I have a very hard time differentiating between, that what people call rolling PEM and that decreased baseline.
I think that is something that obviously I'm not the human experiencing it. I'm getting that from my patients and their experiences. But I would say that when we struggle to find where that line is, I almost always think that the strategy is we actually have to assume that they are in a rolling PEM of some kind and figure out a way to pull them out of that for a while, even if that means taking some more than usual extra relaxation or time off or recovery time to try to elucidate that difference. And it's not, some of that is just so that people understand and feel the difference, but also I think when you're in that baseline state that's no longer that rolling PEM where you can't tell the difference, when you can feel that baseline state and the difference, you start to be more aware the next time of when you're creeping up on that line or when you're going to cross into it. And I think also if you don't pull someone out of that position, you're going to have a hard time again initiating other mechanisms of treatment that are going to help improve that baseline further. So I've unfortunately for some people I've had to say, look, I think we literally just need to take 2 weeks off and really try to recover. This is not going to be time that is fun. This is not going to be time that is, by any means good for engaging with family and friends and such, but it may, on the other end of that, and often does, allow the goal that the patient has to, interact with somebody or do a certain thing. It allows them to get to a point where they can do that without being consistently interrupted by their metabolic inability to do so in PEM.
This is an open question if for anybody who wants to answer it, but given that need for being able to monitor and as much as possible not be in PEM, has anybody experienced or seen patients going too far on the other direction where the activities are reduced way below the actual capacity, or that capacity is not even known, just trying to stay out of PEM, indefinitely?
Well, I've done a lot of talking, so I definitely want to hear from everybody else as well. But I will say there are two scenarios where that is true, I think, Isabel. One of those is people who have been sick for a long time and learned where their threshold was a long time ago, and are terrified of ever going back there because every time they entered PEM, it felt like a horrible setback. It lasted for 3 months. I mean, it was just an awful scenario. And that in the interim, what has happened is, in fact, that they have experienced some of that improvement in their threshold for PEM because they haven't had it. And perhaps they've been working with me or another provider and actually adding some therapies or some interventions that have actually additionally supported physiological effort that extends their reach until they get to PEM. And so there's a point at which you do need to actually encourage patients to test that line a little bit and to expand their capacity in a safe and monitored way. But often you'll find that people actually have a better threshold than they thought they did if they've avoided it for a long time. So that's certainly one of the scenarios in which I think people take it a little too far. And then the other is probably when there is a post-exertional symptom exacerbation, like a severe sensory sensitivity, maybe, again, really severe POTS when you're upright. And yes, that does drain the energy envelope. And yes, those things very much can contribute to PEM. But sometimes those symptoms themselves are so severe that they're actually the rate limiting step and not post-exertional malaise. And so to not attempt to treat those or mitigate those because we fear someone's in PEM, I think is a mistake. So again, a very hard differentiation to make, but worthwhile to try to figure out when working with somebody.
Yeah, and I experienced way more post-exertional symptom exacerbation than PEM itself in frequency. Yeah, so very big
And
differentiation.
maybe a way to think about it on a personal level is it are you getting to the place where you're out of bounds of your energy envelope, but you can come back in bounds and you're okay, or are you out of bounds and now you've kind of gone over the whatever the threshold or the barrier is, and that puts you into a new state. And the potentially a way to monitor that or look at it is really just straight off your heart rate. So if you can figure out what heart rate is tolerable for you, and it might be what you have lying down, it might be what you have sitting up, it might be you can walk around the house fine, but then if a friend's over, as people were saying, that makes a big difference. Lights on, sensitivity, too much music, and so on. But if you use the heart rate as the limiter, then you can also go one step further to say, hey, if I'm lying down, what's my heart rate? If I'm sitting up, what's my heart rate? Does it jump up immediately? And that can be more of a of a of a POTS or an orthostatic intolerance just straight away. So can you go upright and then go back down, and will your heart rate come down? Or when you go upright and it goes up and you come back down, and after a minute or two or three it doesn't come back down, then you're in a sort of a state, a new metabolic state, and those can be kind of nuancy clues, I think, clinically to work on.
One thing that you mentioned heart rate, but one thing that we really, I think, track that maybe filters out a little bit of the variability from dysautonomia and positional change and just, I just went up the stairs and I'm recovering, is heart rate variability. When people's heart rate variability worsens, you can often try to associate that with a change in physiological state. So people use wearable devices, et cetera. They wake up and they're like, oh, my heart rate variability is way worse today. I might be in a bad state. Or then they wake up another day. Actually, it seems like it's starting to improve. And then they feel like they can kind of test the limits a little bit. Often I would sometimes, depending on the patient, but if they very easily fall back into PEM and their heart rate variability is just starting to recover, I'd say, hey, take one more day, let it keep recovering, and then kind of get back into life from that point. But a lot of people have found that that's pretty consistently different from their baseline if they monitor regularly, and a good way to sort of know if they're in PEM or not.
Sabrina, can you tell us a little bit about the work that you're doing in Canada as well?
Sure. So I am a person who's been sick with ME for 18 years in 2 bouts. I was sick as a teenager for a couple of years, and we didn't really have clear understanding except that I had mono. But it went on. And then I went into a remission, didn't know it was a remission because we didn't have that language and I didn't have enough information, but came out of it 16 years ago. And so I was really angry and frustrated at how long it took to get diagnosed, at how much incorrect information I was given, disinformation. I was so frustrated that I went to the States and I saw a clinician there who was actually knowledgeable. And she told me the truth for the first time about what I had and how sick I was. She gave me information about what we could do and what I needed to adapt my life like. And I came back to Canada and I just thought, I've wasted years in the Canadian system just being bounced around. There's got to be a better way. Why is this happening? And very quickly found myself on the research side, because realizing that clinicians take their lead from research. When we don't get the research right, we don't get the clinical picture right. So I've been working, myself and a group of patients co-founded with Dr. Moreau, the ICAN-CME Research Network here in Canada. And we work really hard to try and recruit people into the space that don't know about ME, or if they do, they probably don't have the right information. They receive minimal training or no training at all. So we do medical education for them, which we've had Dr. Braden in to help us with that, and the team at Bateman Horn, which has been wonderful. And we also do a lot of work with researchers directly, where we create a safe space essentially for them to ask us all the questions that they don't understand about ME. PEM obviously being one of the areas where I would say we have the most dialogue and discussion and the most frustrations. Also, our criterias come up a lot. The fact that they don't know which one to choose and how they work and why you would choose one over the other. And I also do a lot of work with support groups here in Canada. So we have thousands and thousands of patients that we can actually watch patterns in over time. And I will say that's been really helpful in terms of kind of fueling my understanding or my work in the research space and the clinical education space, or the medical education space, is watching us talk about a particular medication and then watching hundreds of comments happen around that medication and thinking, that's interesting. Some people are seeing a high, some people are seeing a low. Then we ask them to switch doses, for example, and go lower with their doctors, slower. Suddenly we see a higher increase in success. So it's stuff like that. It's really kind of trying to listen to the community as much as possible, and then taking that information back into the research and the clinical spaces and working with anybody who's curious. And I mean, ME is a fascinating illness. Everybody should be interested. It's multi-system. No matter what area of the body you're interested in, there's something for you. So that's basically our pitch and our sell really is come join us with your skill set and like whatever you're interested in, we've probably got something for you.
Well, Dr. Phair, go ahead.
Sabrina, I wanted to ask you about the cuff massage that Alain Moreau has invented to simulate PEM. I want to know if patients who have undergone that perturbation of cuff feel that what happens following the cuff is similar to their everyday PEM experience.
That's an interesting question. And Dr. Moreau and I have had a lot of conversations about the cuff. So I am skeptical of the cuff, partially because a lot of us use devices that are compression driven. So I call them my compression boots. I don't know what the correct term is, but it was Bateman Horn who suggested them to me and they're wonderful. But they provide ongoing compression for a period of time. And I don't crash from that. And so I have some questions around that. When I spent some time though with a lot of the people who had gone through the program, and Dr. Moore and I have talked about this, I asked them if it was the cuff that had caused their PEM and how they could be sure. And they were initially like, yeah, it was the cuff. But as we got talking, I realized that like some of them, for example, had been quite nervous and anxious and excited about, being part of research, and they were on the more severe and very severe side. So that alone can create PEM. Then there were questionnaires, there were nurses coming into their homes. Some of them were feeling really badly about themselves. So like they said to me, like I went around and tried to clean up a bit before the nurse arrived. And I was like, well, that could cause PEM. So there were so many confounding factors that hadn't been controlled for that I think for me, I'm excited to see where the cuff goes, but I think we need to actually validate it against kind of what we already know and then be able to move towards things like that, but also cognitive test. I think we can trigger PEM through cognitive testing, and I think it's a lot more accessible. It's a lot easier. We could make it happen in people's homes. I mean, reading a book, most of us would say that reading a book is one of the most difficult things you could ask us to do. So if by that standard, there's probably a way that we could create something that could be accessible and could help to measure and maybe at different gradients for different levels of severity. So some of the work that I'm involved in with the NIH right now, we have a PEM group actually, and we also have a cognitive group that's looking at the common data elements. And I think the cognitive group in particular, there's a real interest in like exploring going forward, like what could we be doing in that area and where are the gaps in that research and what could we do? So I think the cuff is interesting. I think lots of things in our space are really interesting, but I think they require more study and they require more controlling for variables to be really sure of what we're seeing.
Veronica.
Hi, everybody. Thank you very much. Dr. Yellman, I've been wondering after what you've been saying today. I'm not basing this in any specific research. I'm just kind of wondering about it. If we are thinking about this recovery time that for most people kind of, helps to go up on the baseline, could this be a combination of really allowing time for mitochondria to kind of reproduce, let's say the healthy ones, and at the same time to train our nervous central system to really calm down? Because what I'm finding here for everything that you've been saying is that there is a very fine line between the POTS and the PEM. So that really means if we think about it, everything that we do is interconnected, but at the same time is controlled by the central nervous system. So is that where we'll give in that little space for the central nervous system to really calm down generally and kind of find a space to be regulated again? And at the same time, we allow for mitochondria to come up. Because I've been wondering so much about, with the medical culture that we have and the little time that we spend listening to the patients, it's almost impossible. Like, I mean, this will be a dream to have that much time to really kind of examine each single case on a day-to-day and what they are doing and just take them by the hand and, walk with the patients and say, what we can improve. But if we think in terms of mitochondria, probably we would get to have a biological test where we can follow this and see if we really are improving that kind of biological energy. Because, sorry to go that long, but the other thing that I find is that culturally, even when we know that everything that we're talking here is science-based, when you try to talk to other people that are not in this realm, they think you are just going, to the kind of mythical side of the biology and the energy. So we like it or not, even if we are convinced that we don't need biomarkers, unfortunately, to show it to the world, we need biomarkers. Sorry, did I go a bit too humble?
Dr. Haughton, would you like to respond first?
Sure. So I think as your statement's getting made, it pops an idea or a thought of if mitochondria growth occurs when the body's in growth versus when the body's in protection. And if in a healthy athletic population, say, you tend to get growth during high resistance, high activity effort, then is there and if you were to look at the whole piece of PEM as being crossing over the anaerobic threshold, and so you're just in an energy deficit state, or the event of having that happen, is there information potentially really useful to be learned from what I suspect is a deep body of literature in healthy athletes about what creates mitochondrial growth and what environment does it and what happens when you are taking in oxygen, when you're doing all things? And that's a group that we know has really good circulation already. And then we think in this population, certainly in long COVID, if not others, that some of the microcirculation can be impaired. And so if we can pull out the variable of circulation by looking in that other literature, it just dawns on me there may be some incredible clues there of what is the bathing environment that will allow for sustained growth. And I'll say one more thing and then stop. This timing of a month to 3 months of seeing something happen as a cycle seems to be very real clinically in lots of different versions of it. And it feels like it's the amount of time that so if somebody breaks a leg, it takes 8 to 12 weeks or so to heal a leg. If you have a really bad wound, same thing. It takes, and so it's a period of time to go from acute degradation to throwing materials in to make it better, and then giving enough time to recycle it, which means getting the new vessels and growth in there. And I think that it's my words aren't super clear here because I'm sort of swirling around an idea, but it just popping it out there may be incredible learning for getting mitochondrial growth and resilience from the athletic group.
And similarly, there's been a lot of look into the aging literature and trying to understand the role of mitochondria here. Yeah, I love one of the, I've actually used this as well, one of the analogies that you just kind of spoke to, the broken leg analogy. Like if you're in post-exertional malaise, think of it as like you just broke your leg and hey, I had the surgery, the bone is set, now I want to go running again. It's like, well, you got to start putting weight bearing first, then you got to start walking and you got to heal over time, right? So to the question, Veronica, that you kind of put forward about the nervous system, there is, I think, undeniably in most people with ME/CFS, a degree of autonomic nervous system dysfunction, and that can be neurovascular dysfunction, right? How the blood vessels are behaving, but also how the kind of fight or flight or rest and digest nervous systems are working peripherally. We refer to something called sympathetic overdrive, or a lot of excess sympathetic signaling, or exaggerated or inability to turn off sympathetic signaling. Sometimes it's turned on by a stress, whether that's an orthostatic stress or a physiological stress or a mitochondrial stress, but it can be really self-perpetuating. And so, is somebody avoiding PEM for a long time, is that in fact, letting their nervous system calm down, and then their nervous system is not driving them into PEM, not being one of those drains on their overall energy envelope. That's certainly possible, but I think you could also argue that if somebody is successfully achieving no post-exertional malaise to begin with, that they're actually avoiding triggers that would kick their sympathetic nervous system up, whether that's an orthostatic trigger or a inflammatory trigger, et cetera. So I feel like that's a very kind of chicken or the egg type question that's really hard to answer. And in fact, it may actually be different in different individuals. I think different people have different thresholds or primary driving symptomatology, and the art of the medical aspect of treating this is trying to identify, for John Haughton, what is the specific rate limiting step that we have to overcome if we're going to make any progress with these other aspects. To the idea of mitochondria in general, I think for patients, it's extremely helpful to think about it in the ways that you were just describing, Dr. Houghton. And I think that, thinking about your energetic threshold and how much energy can be produced by the mitochondria and what things actually tax that, and the fact that they probably have a lower capacity, conceptually than other mitochondria is a great way to think about it. But on the, I guess, scientific side of things, I think it's a lot more complicated than that. It may be that only certain mitochondria are sick, or in certain tissues, there may be an aspect of how mitochondria behave that is controlled outside of mitochondrial dysfunction themselves. So is the immune system giving signals to the mitochondria to behave in a certain way? Is the general neuroinflammation that we understand is going on, is that sending a signal to certain autonomic nerves that then tell the mitochondria how to behave? And I think we also are appreciating that mitochondria, as much as they teach you in every biology class in 9th grade that they're the powerhouse of the cell, they actually do quite a bit more, and they're involved in all kinds of cellular signaling and production of other molecules that are really important for general function. And we're just starting to scratch the surface of understanding the connection of mitochondria to these other features. And actually, with that in mind, I would love to hear more from Dr. Phair, who's thought a lot about mitochondrial dysfunction in terms of mechanisms for this illness.
Well, thanks for the lead in, Braden. I actually think that the big question in my mind, listening to both you and John and Veronica, is whether you think the mitochondria in the patient are damaged or are in some different control point. I'm not so sure that there is mitochondrial damage. I think we are experiencing modified control system. Is moved into what John described as another physiological state. Happens to be pathophysiological, but it's another physiological state. And so I, as you said, Braden, am thinking a lot about the control systems around the mitochondria. John and I talked about one before you logged on. That's the HIF1 alpha control system, which can be initiated by mitochondrial signaling to the cytosol. And then all the HIF1 alpha is a transcriptional regulator, which controls gene expression, and is probably the mechanism by which glycolysis is shut off in conditions where you have aerobic glycolysis going on. So I think you're absolutely correct that mitochondria can do a lot more than be the factory that produces ATP from ADP. And many of us in this group of panelists are interested in the systems view. There are a bunch of engineers here, and I think we're lucky to have all of them talking with people who have spent their whole lives on the medicine of this problem. I'm glad to be here.
And I think around the systems part of it, MCAS and mast cells releasing histamines, and whether they're sensitive so they release more, or they've got more tryptase coming in so they make more and then release more, or you do antihistamines to stop the receptors from receiving it, that's a loop that can drive inflammation. And then one of the things that can make mast cells degranulate is low oxygen anyway. So you can get low oxygen in tissues, and hypoxia, it can drive that loop. And then the idea of healthy or not healthy mitochondria, maybe I'm in an impaired state in my brainstem because I'm in a watershed vascular area, but I'm in a good spot in my skeletal muscle because I never have pain in my muscles. That might be a different picture than I'm super sore and my legs feel like concrete, but I can think crazy clearly. And so at different places in the body, having different blood flow, and then the reality of lying down versus sitting up. So I'm doing great when I'm lying down, and now there's not enough flow when I'm standing up or sitting up. And then add all those sympathetic things. You've got the dynamics of how much oxygen is getting in there, how much blood is available to deliver it, and then how much reactivity in the tissues is there related to all the mast cells. And then you get inside the cell itself and say, what's happening with the mitochondria, what's happening with the HIF, and so on.
Yeah, I'm curious from a practical perspective for both research in the immediacy before we are able to develop common terminology and definitions. How can patients best describe their state, and how can researchers take that into consideration, but how to interpret the information? So for example, personally, if I get PEM from an emotional, exertion, stress, the symptomatology that I experienced during that PEM event is very different than what I experience with physical exercise. And it's different than what I experience with cognitive exertion. There is some overlap in there, but it's not one and the same in those different states. So, and I guess both from the management and the clinical perspective, if I were to be in a research, project, and I'm experiencing emotional PEM at that time, what the measurements may reveal are going to be different than if I was in physical PEM at that time. So how do we do a better job now, both research and clinically, from a practical standpoint, to capture those factors? Go ahead.
I don't know if you're asking me to go ahead,
Yes,
but I will.
yes.
So, I was going to ask you the point you made about the different symptomatology you see following different triggers is contrary to what I was taught when I first got into this field. What I heard was PEM is an event caused by exertion that exacerbates every symptom you have. And you're saying it's different on different occasions. Is that correct?
It is. Yes.
Yeah. And so when it's cognitive or emotional, are the symptoms that are exacerbated the ones that you would attribute to brain function?
For cognitive, 100%. For emotional, no. My emotional PEM is very much felt physically. And my muscles will get sore like I just try to run a marathon.
That's really interesting. So this is one of the basic questions that Braden and I have talked about many times, and that is, how is the exertion transmitted to this other part of the body? Do you think there's a systemic signal? Or is it the nervous system that's conveying your emotional PEM or your emotional exertion to your muscles?
I don't know. I don't know the answer to that.
I don't either. And so, is there anyone who thinks they know? What's the hypothesis out there?
Maybe.
Maybe.
There's certainly there are quite a lot of theories. Recently, I've been doing a pretty deep dive into the TRP. I call them sensory ion channels just for ease of handling, even though they're not quite all sensory. But they seem to really sit at the intersection of a lot of the systems that all of us and the researchers that came before us have looked at, and are often key regulators of physical exertion, right, requires an appropriate response to TRPV1, which has been shown to be altered in ME/CFS. Emotional exertion often includes TRPM8 and the kainate glutamate receptors, which I had been looking at previously. A lot of chemical sensitivities have been traced to TRPA1 or TRPV1. So there seems to be this little cluster where the ion handling is altered for us at some base physiological state for some reason. And all these different types of exertion will trigger a cascade in that system, which then, causes all the other things, including potentially mast cell degranulation, which can cause, any symptom in the world. But of course, it's a theory, right? So much more research.
I love theories.
I'm struck by Isabel, your statement of and quite back and forth with Dr. Phair of the distinction between emotional and cognitive, and in the brain, and that with emotional, you're getting your autonomic nervous system changed in some way, shape, or form. Could be sympathetic overdrive, which is going to cascade all down through the body. And the cognitive piece, to do cognitive action, requires cognitive energy. And if you're in a tenuous spot, you can get inflammation, which would then, presumably by nature, stay in the brain. And so it strikes me you could have, if the blood-brain barrier ends up keeping inflammation in the brain a little bit, and same in the body not getting into the brain, which is an oversimplification, then that teasing out that difference between cognitive and emotional could be really, really helpful clinically and for descriptive purposes. And then I'll say one more thing and stop, that within clusters clinically, they're definitely folks that are, my brain's clear, but my GI's messed up, or my skeletal muscles messed up, and I'm crashing, I can't sit up, I can't do the energy, but I can still think clearly, which suggests there's some kind of phenotype that has some distinction in the body.
Absolutely. Sabrina, you've had your hand up for a little bit.
I love all of this. I think this is where the conversation needs to be. These are the kinds of things we need to be talking about, and too often we don't hear these kinds of conversations happening in research. And when we do, unfortunately, patients are sometimes not in the room or not centered enough to be sort of part of the conversation. So I love this. One of the things I will say is I've been mild, moderate, severe, and very severe at periods. And I was able to come back because of access to some clinical care that really made a difference and a layering approach to medications. I'm on a fair amount of medications. I'm not going to lie. My pharmacist is like, whoa, even to be able to do this, I have to medicate. And I've been able to come back to a place where right now I would say I'm on the cusp from moderate to severe, and I kind of can trip on either side of that line. When I was mild, my physical PEM had more physical symptoms, and my cognitive had more cognitive symptoms. And it was a lot clearer and cleaner for me to kind of divide that. And I'll be honest, as I moved across, everything started to flare everything, and everything started to get quite messy, and everything tripped everything else. And then the comorbidities, as you get sicker, the comorbidities get either you get more of them, or they get more progressively problematic. And so I always tell patients, do not raw dog this illness. This is not an illness we raw dog. It's so hard because we don't have knowledgeable clinical care, and we often have to be advocates and champions for ourselves and educate our clinicians. And thank God for those of you who do the great work that you do to make that easier for people like me. But over time, and it's been many, many, many years, the medications that I've been able to take have pulled me back from the brink. I had lost hope for myself. I hadn't lost hope for the community, and hope. I'd never lost hope for research. I'm a big believer we're getting there, and we're getting there with treatments and answers. And I think one day we could see a cure. But I had given up for myself the fact that that would hit in time for me. And I just want to like really, for those who are listening, like I am laying down right now. It's not really obvious because my head's elevated, but I am laying down. And I just want to say, for those who are sitting there and feeling like we're having a conversation that's not connecting with your experience, I totally get it. We're kind of talking up here, and some of it is hard to follow, hard to understand. We're talking about the differences of different experiences. But this is the conversation that needs to happen, because PEM is so dynamic. Catching it is so difficult. And I think, going back to Isabel's question, you know, how do we do that? I think one of the things that I've been thinking about for a while is I think we almost have to like measure people against themselves. Instead of measuring me against Isabel, because I've been following Isabel for a long time and love her content. But I can tell that Isabel and I have a very different experience.
Yeah.
And hers is valid and mine is valid. But if you study us together, you could end up with sort of a, oh, it's only 50% of this, or it's only this of that. So I think that being able to like get our language cleaner and clearer, and our definitions much, much cleaner than where they are now, is important. I think then designing studies that look longer term, which are more expensive, right? That's why they're not happening. We're a chronically underfunded illness, and the kinds of studies that we know we need to do, like, no offense, I'm not that smart. I'm not coming up with anything we haven't all thought about a million times before. It's the money, right? We need the money to be invested in the right way. And I love this Innovation In project that you guys are talking about doing, because I think that's so cool and might be like such a cool thing. Hopefully I'm not saying anything I'm not supposed to say.
And you're not, and looking at the N of ones, you know,
Yeah.
as you just mentioned, that measuring one person against themselves and not the next. And what you said about, you know, the different characterization in the different severity states, and someone in the comments also mentioned that their experience is very different. My experience was not as clear as it is now in the times when I have been much more severe. You know, and that's a distinction that we also can make. My PEM used to be pretty much the same for all triggers. It's differentiated now that I'm in a different space.
Yeah, so I think it's like we need to look at severity. We need to look at what medications people are on. Like, we really need to track medications that people are taking. And I think we need to track comorbidities more effectively. Understanding what comorbidities are in the equation helps us to understand, like, if something is happening and we're seeing like heart rate variability change in some but not others, like, is it the dysautonomia responding? Is it a medication that's in the mix? You know, and so it's that really expensive kind of research where we have to deep dive a group of like 100 people, watch them over a longer period of time, measure them against themselves, and then do comparisons as groups. And I think like all of us know that. It's just, you know, for me, it's like if somebody, you know, who's super rich wants to reach out, I have people who want to do this kind of stuff, you know, we'd be delighted, but we don't have the money.
Veronica.
Thank you. I'm going to touch quickly in various points. And John, from what you said, you made me think about, you know, how many athletes who would imagine they were in top mitochondrial shape, for calling it one way, how they have crashed sometimes at the first COVID infection. So I think you're very right. You know, that will be a very interesting point to look at those specific patients and look what happened. I mean, probably it's a little bit too long ago, but still, I think that would be a great clue. Isabel, from what you mentioned about this connection between patients and medical doctors, I think, and I know probably is not a point for the community that has been dealing with this and that has known that they have ME and that they have long COVID for a while. But for other patients, I think, unfortunately, we'll even have to go one step back and teach people how to feel their own bodies, because that's not part of the culture. So probably, like, I was an athlete when I was young, and as an athlete, you learn how to feel your body because that's part of your performance. But most people have no clue. Even if they do sports kind of, just for fun, they really don't understand their own body. And I think that's the first clue. And if you think about the communication between the medical doctor that doesn't have that feeling either, I think we really need to go quite a long way back. And in terms of the tests, sorry, I'm a chemist, so I kind of think a lot about how we can set up a biomarker. And I mean, we've always been so wrong in the way we test, because we always think of an easy way of taking a sample. So the first sample we always think is blood. Sorry, but if we think about blood and this idea that is not all mitochondria, because that will be actually crazy to think that each single mitochondria in each single tissue is damaged, we have to even think about a different way of sampling for mitochondrial tests, because probably that will be one of these clues that you were thinking about, how do we differentiate the PEM between the physical PEM or the cognitive PEM or the emotional PEM. And just as a last quick point, in that emotional PEM, I think we also have to consider stress and all kind of the neurotransmission that goes along with stress, because that will impact a physical body very hardly. That is not the same that is only coming from a physical exertion. And I will stop there.
Thank you, Veronica. Kat.
Wow, just like, yes, this is the conversation we need to be having. And particularly that point about that there are times when our PEM, like, regardless of the trigger, seems to be basically the same. And there are times when it is different. And it seems like for a lot of people that tracks with severity, but we don't know, we have to do a little bit more, discussion and data collection to see if that is a pattern overall. But I think it's a very, very important discussion to be having. And I do wonder if there will end up being, some insights into targeted treatments for that individual. And in particular, as Dr. Yellman mentioned in the very beginning, also how we use treatment in and out of PEM being quite different. But that all aside, there was a question in the chat that I wanted to relay that I think was very interesting and very important. And that is the idea of a PEM prodrome, like the way there is with migraines, where there's sort of like a warning period before it really sets in. And this is something that I have experienced and was a little bit baffled by, and only at certain points, right? It's actually not something I was experiencing when I was more severe, but is something that I've experienced much more over the last 2 years. And I wonder if there is a commonality there. And if once we start noticing that prodrome, is it already too late? Or is that like a spot? Is that an opportunity for a different sort of intervention that is not our baseline stabilization type medications or supplements or other things, and is not necessarily our pure rescue during PEM, just, deaden the symptoms so it's not so miserable? Is that prodrome more common, and is it an opportunity?
And for me, I will say that prodrome is different than post-exertional symptom exacerbation. Very, very different.
That's a very key,
very
that
distinguishable.
distinction.
Yeah. Dr. Yellman.
The prodrome question is a really interesting discussion point that I do honestly I'll come back to. And yes, I've had that reported by a lot of patients. And I think there are some interesting thoughts there to go to. But I did want to kind of come back to the initial question that you had posed there, Isabel, at the beginning, which is, why is it important to even be able to determine post-exertional malaise, and how do we help people do that? And I think from a study perspective, right? when we do a blood draw and we're trying to learn something biological about ME/CFS, is our data getting a little bit muddied or confused by the fact that some people are in post-exertional malaise when we draw the sample and other people are not? Similarly, if we are doing a clinical study and we're trying to give an intervention and somebody has a side effect or they're just not responding to the intervention, is that because they're in PEM or is it because the intervention doesn't work? And I fear that a lot of the studies we've done up to this point and all the other doctors who come in and say there's not enough evidence to treat this or to use LDN or to do whatever we do, that we're missing an opportunity to have more power of detection in studies by not differentiating post-exertional malaise. I mean, there's even the common clinical scenario where it's like, okay, I give a patient an intervention, they start to feel a little better. Maybe they don't even realize they feel better, but their energy envelope's a little better. They do just a little more, they cross over into PEM, and then they see me a week later and they're like, I'm doing worse than I did last time. Well, you might have done better for a day and then you did more and caused yourself to go into a deeper PEM. So until we can really help people identify these differentiators, I fear that we're not always getting the very best data or designing studies in the most optimal way possible. And yet it's really a huge challenge. How do we help people, as we talked about before, differentiate between the prodrome and post-exertional symptom exacerbation and PEM that may be more cognitive or more physical? And again, I think it has to start, as we brought up before, with comparing oneself to oneself. I wonder if before people go into a studies, if we and I'm curious to hear the patient perspective on this. If clinicians and researchers try to describe PEM, try to have the conversation that we're having today to sort of help people see the differences or pick out, okay, I've had that, but I've also had that, so that they can report a little more accurately, so that ultimately when we do studies, we can differentiate between what is really the problem here. Like, is PEM actually the interfering with our data quality or not? And we can always supplement that with heart rate variability trackers and wearable devices and other biological tests and biomarkers. And we really should be looking for a confluence of all of those things. But even in the short term, is it helpful, do you think, when somebody has a new diagnosis, for them to hear a conversation like we're having today to better understand PEM? Is that going to help them clinically and help them report for research better than maybe we're currently doing?
And you and I were talking yesterday about how do we remove the bias, right? And those the questions themselves can bring that on. But if we're able to ask the questions in a way that is asking for the information for a particular set of circumstances, whether the patient and the researcher and the clinician are using the same terminology to define that set of circumstances, I don't think it matters. I think it matters that at the moment that they're being answered for that particular set of wording within that question. So if I define a crash as losing power completely and not being able to do anything, and somebody else defines a crash as a prolonged PEM, right? If the question is, do you experience a time where suddenly you lose all of your energy, you're not able to do anything for, this amount of time, then it doesn't matter who defines a crash as what, because I'm answering that particular question, and that can be considered for, the care or the research.
And you mentioned something that we've talked about before, Isabel, that I think is really important, and I would love to hear some patient perspectives on this. We talk about bias in reporting of post-exertional malaise. If you are a patient and you have been gaslit and you have been passed around from doctor to doctor, and you're trying to get in to a certain clinic, or you're trying to be included in a research study, and you clearly are suffering greatly, but you fear that if you don't report PEM a certain way, that people aren't going to believe the severity of your symptoms, you might be, subconsciously even inclined to report things slightly differently. And I wonder how that affects things, if that's a real scenario that patients have experienced, and how they kind of how they process that, how we look at that and maybe do a better job, but still help everybody feel included and important and like their symptoms are valid and as important as anybody else's.
Yeah. John.
Yeah, this is a quick aside on something I saw today. I saw, I guess it would be a meme of somebody saying, "Oh, if I answer I'm fine, it means I've taken a mental calculation that I don't want to invest the time to really understand what you're doing, and then maybe you judge me and gaslight me and have blah 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 blah. I'm fine," and so it has essentially no meaning whatsoever. But I want to go back to the place where the description of when severe, a lot of the symptoms wash over and have trouble. And when less severe, there's more nuance or more segregation on which symptoms hit. And in thinking through that, I wonder if that level of severity potentially could be related to the amount of cellular damage that's getting done. So if you're severe, you have cellular damage getting done. And then if that happens, does that mean it's a period when you're freeing up more cell-free DNA or more extracellular ATP or viral crud, so RNA? And so is that marker of severity maybe, if that's the case, then you would expect potentially more of a washover. And then if you think of the details of where are the danger receptors and the amplifiers, some are on the surface of the cell and some are inside of the cell. And so how do those work together? And the one that always strikes in my head is the toll-like 2 and the toll-like 4, where 2 is sort of typically on with Lyme and 4 is typically on with mold and COVID and microplastics and other things. And if somebody has both, you get a stronger immune response. And it feels like there's something potentially in there. And then the last thing is I think clinically, one of the most dangerous times is feeling better. So if you're feeling better and you've been in PEM, or it's that there's just such a natural tendency to want to go for it. And if you're in the, if you have a sprained ankle and it's not hurting, it's not swollen anymore, if you go out and run or just sprint or do something, you're going to injure it again. And that it's potentially the same thing here. And so something that maybe I share with people clinically that hopefully is useful is if you feel like you can do 5 things today because you're having a great day, do one of them and wait till tomorrow and see how you feel. And if you're still feeling good, then try 2, then try 3. And just if you can avoid that, I can do it, and so I'm going to go for it, because it's just like a sprained ankle re-injuring it, I think.
And I think that sometimes patients hear that and they feel like it's conflated with graded exercise therapy, which is not at all the same. Graded exercise therapy is when someone is trying to get you to exercise and do it slowly and trying to improve you by that additional exertion. While what John is referring to, something that I also talk a lot about, is testing your new baseline. So Dr. Yellman spoke earlier about, if you're able to take that 1, 2, 3 months of extra rest and avoiding PEM for all of that time, or maybe you have, new interventions that you're feeling much better with, is you don't know now where that threshold, that improved capacity is. And if you go above it, on the first go, then you're going to find yourself again in PEM and, potentially have that regression. But if you test that new capacity little by little, you can potentially determine where that threshold is before you hit it. And that's a big difference.
And just on the graded exercise, so if somebody says, do 1 thing this week, 2 things next week, 3 things the next week, and so on, and doesn't say how are you feeling? How is it affecting you? What's going on with it? To me, that's the idea. That's graded exercise therapy. So it's gut through it. Just keep pushing harder, no matter what's happening, and do it by calendar. Versus what we're talking about here of checking. You feel great. Don't do as much as you think you can. Just wait a few days on your own, because if you do 2 of the 4 things and feel lousy tomorrow, then you've potentially made a softer crash than you would have if you had done 4 things and then felt really lousy tomorrow.
Yeah, yeah. Sabrina.
I just want to come back for a sec to what you were saying, Isabel, when you were talking about language, and I'm a little foggy at the moment, so I apologize. I'm going back a few steps, but we were talking about language and PEM and sort of how people define crash, and I agree with you. First of all, I always tell researchers, don't ask people if they're in a crash or not. That is, if we've learned anything from our first conversation together, I am so adamant about that now. It's like, ask really specific and precise questions, so that no matter how they define it, you're going to get what you need out of it as a researcher. But I think there's 2 areas that we really need to recognize, acknowledge, and move forward. And one is tool development. We do not have great tools for ME research. We are using surveys that are at best less harmful sometimes at trying to capture the experience of ME. And I've participated in some wonderful research, and I've participated in some awful research as a research subject. And I've helped a lot of researchers do this stuff. And I will say that, like, you know, some of the common ones that would be considered validated, although again, we haven't really validated a lot of the tools that exist in ME with an ME population, but we would accept them because they've now been used enough that we just kind of say they're fine. They're really minimally able to grab things like fatigue or pain or something like that. And PEM, listen, the DePaul questionnaire took us from where we were 10 steps forward. Thank God for that questionnaire, because it moved the needle in the right direction for us, and it was so important. But it isn't the end of where we need to go. It's a step in the process. And I think there's some really important tool development that we need to think about, where we start to really ask the kinds of questions about PEM that we need to ask. We need to measure over longer periods of time. We need to be able to do a little testing, maybe a little provocation, gentle provocation, and just see what happens. So we do need to invest. And by the way, I tell this to all the people with money. We need deeply to invest in provocation testing, but also in tool development. Those are 2 areas that until we do that, I feel like we're going to continue to stay stuck. The other thing is that I spend a lot of time in rooms with people who are brilliant and smart, but I feel like we're, as a community, lacking the courage to really define PEM and PESE in the way that we just need to do it. And sometimes I get people say, well, we can't change the definition of it, or we can't make it this clean, because if we do this, then, you know, we might be leaving somebody out. When we don't define these terms clearly, we're leaving everyone out. It's a mess. It's a hot mess. We're not getting anywhere, and everybody's defining it slightly differently. And you could talk to 10 researchers and they would all, I've been doing it lately just for fun, asking them if they understand what PESE is and PEM is and how they would define each. And it's a mess. And some of our best clinicians in Canada who care and are trying to learn are not able to define them. So I think we need to, like, really get a good, clear handle on it, even if it's imperfect, even if maybe 10 years from now, we're going to look back and say, you know what, maybe we shouldn't have said delayed onset. Maybe, you know, because my definition is delayed onset, delayed recovery, disproportionate to the amount of exertion, and loss of function. That's how I define it for people. But for some people, they're like, no, it happens right away. And I'm like, I think there's overexertion red flags that happen right away. So I have overexertion red flags that I can feel come on. The back of my skull swells. When I know that that's happening, I have a period of time where I can intervene with emergency meds and take that down and maybe skip PEM. If I don't act fast enough, I'm going to get PEM. I also think I've been sick for a long time. I've had a lot of time to study my own body. And the longer, you know, that you're sick, so sometimes mild patients are really new to the experience. So even though they're mild and things might be cleaner, they don't know, going back to, I think, what Katrin was saying, they don't know that sort of experience and how to talk about their own bodies. But when you're further along the process and you're blessed enough to have a couple of medications that are working and it pulls you back and you have enough time to study, those things start to become really clear. So I think we actually do know. I think COVID has really confused the definition of PEM. when I first got sick in the community, pulled me aside many times, our elders in our community, and said, it's like the Mack truck that's hitting you in the face a couple days after you've done something. That for me was really simple. In COVID, suddenly it's been conflated that every symptom that happens post-exertion is now all PEM. And I think we've done a huge disservice to the patients by allowing that to continue, because we have people who I can tell don't have ME that are diagnosed in the community because of that misunderstanding of PEM. No criteria used. You come in, you're kind of like, you're feeling bad the next day. Yeah, it's PEM, good to go. I'm like, no, go and read up the definition. Maybe you don't even have ME. And if you don't, there's a different path for you, right? Everybody's important and everybody matters. And every presentation of these things matters in the infection-associated chronic illness community. If somebody has POTS and they can benefit from exercise, I don't want them laying in bed resting if they can benefit. So it's like, I know we're all on the same page about this, but I feel like it requires courage to come out and say, we need to redefine PEM, PESE, and maybe define where prodrome sort of sits in that picture, and like have the courage to like try something new, even if it's imperfect. And even if in 5 years we realize we missed some teeny tiny part of it, I do think it would move us closer in research to where we need to be. It would give us answers, and then we can perfect again in 5 years or 10 years from now. Like, people got it wrong 20 years from now and it was okay, and we moved the needle forward and we got further ahead. So like, we can't be afraid to like, perfection is the enemy of like progress in this illness sometimes.
Yeah, thank you, Sabrina. One quick thing that I'm going to say, going back to my N of 1 presentation of triggers and manifestation of PEM, and how that is different now than it was when I was severe, is I've been developing a formula, which is a combination of different supplements that works for my PEM, and we're going to be studying it. However, what I wanted you guys to maybe think of, and we can discuss this, maybe offline another time too, but is that it works for all types of the PEM that I get, even though they're different, but the timing matters a lot of when I take it to the degree of effectiveness that it has. So I want you guys to, think a little bit about that, and maybe we can talk about the different possible mechanisms that can be influenced in that. Veronica.
Thank you. Well, my first thought is I really wish we will all be rich to set up all these trials, because there's so much to do. By everything that you guys have been saying, I've been thinking about, this that you just said, Sabrina. We need a tool to really track what's going on with people. But at the same time, and I know probably this will sound very confusing, but we cannot have one single set of definitions, because as we know, it's a very personal experience. And I think we have to separate the experience from the perception. Because again, if somebody's very severe, independently of the physiological side of it, I guess everything just feels so horrible that it's very hard to differentiate when you're having certain type of PEM than the other, because you are just feeling rotten. So could we not draw from this that Isabel was saying, to ask specific questions and actually draw a kind of possibilities for how people feel, for example, a crash? I know it's a very ample term, but if we could kind of do this research of studying so many different answers, and they, yes, get to a definition, but it's not like a single sentence definition. It's like, for PEM, you could feel A, B, C, or D. Probably that will help us to really kind of have a better follow-up, in which we don't leave everybody. Like, it's very hard to consider everybody, but it's also very easy to leave people out of the thing. And at the same time, I was thinking, something that Dr. Yellman mentioned, and it makes me really kind of shape the whole idea of clinical trials. Because each single time a clinical trial is done, I've been wondering about this inclusion and exclusion criteria. Because yes, science needs to be strict, and we need to be very careful with who we include and which we exclude. But if we are not careful on really including people. And at the same time, we are not getting to the point because this is a very personal thing. So how can we really learn to develop and to convince people that do clinical trials to not be, we have to be strict, but at the same time, we don't have to be that strict because we are confusing so much data. We have this huge pool of messy data in which we don't know if really that was a good inclusion criteria or not at all. So I don't know, probably I made it even messier, but that's what
I make a big stink about trying to prove of hypotheses rather than understanding mechanisms and differentiators, right? And this is not new, me saying it. Many people have said that we can learn as much from what works than from what doesn't, for who and under what circumstances, right? Because PEM is just one layer of the aspects of, did this work for this person because there was no PEM, and another person because they were triggering PEN as soon as it worked, like Dr. Yellman alluded to. But there is, and again, money is a huge factor, right? There is a lot of simplification that has to be done to maintain, a budget and a time frame and so forth and so on. But if we're not looking at the different aspects of, did this medication work for this person because they were already on this baseline, stability of a combination of other medications that allowed, this one to work. And there is so much nuance that is just not included that needs to be considered. John.
This question about inclusion and not in the studies, I think it makes a strong argument for why it's desirable to do registries of as much practical data as possible. So if you're collecting a registry of data, you're collecting it on everyone, and then signals out of that registry, or when people do observational studies within a clinical cohort or a research cohort, that those can pull signals out that then can be tested. And is the signal strong enough, or is the result important enough to spend that amount of money testing it that rigorously? But having a constant feeder of signals and noise, it becomes really important. And a registry could do that. The Innovation In is going to be doing a bunch of measurement of scatter measurement of really deep investigation at different time points to see what settles out. And I think some of the Recover and other things, there are different researchers out there that have pulled tons and tons of data on a group of patients that met some inclusion, but there's a whole bunch of heterogeneity within those patients. And I think there are tons of signals available in some of that observational data and collected data that we could use of this to cluster more, to find timing and so
on. Dr. Phair, it looks like you had something to add to that. You're on mute.
Either that's a mistake or I've forgotten what I was going to say.
Oh,
Sorry.
That's okay. Melissa, your hand is up.
Okay. So you can hear me okay?
Yes.
Okay. I just had a couple of responses to a couple of different people, and it's a little bit past the time when those statements were made, so hopefully we can circle back around. But in regard to what Veronica said about knowing your body, for me, I just 2 weeks ago took a balance test during a physical, and it was the heel to toe test where your arms are out and you're walking in a straight line. Well, to my great surprise, I completely failed that test. I had no idea that I was in such a state with my balance. And so I knew that my interoception had been affected by Lyme disease and COVID, and that I had had difficulties with it along the way. But I guess that I felt that I was recovered enough that when I did not pass that test, I was so shocked. And so, in terms of what Veronica was saying about knowing your body, I didn't even know that there was something so significant about my body until this came up. And I believe that there have been many times when I have underreported my symptoms. This goes back to what Dr. Yellman was saying. Looking at my bearable data, what I've input for 2 to 3 years, in recent days, when I've gone back to look at it, I thought, you know what? I seriously underreported my pain in this area. You know what? I completely dismissed this symptom that I've been having the entire time, and I didn't even have an entry for it. And so I wonder, well, how valid is my bearable data, considering that I've been underreporting or not reporting symptoms? And part of it is just that one, I'm not really, I don't have a good relative understanding of how I'm doing now compared to how I was doing when I was healthy. I don't even remember, in some cases, what it felt like to feel healthy. So how am I supposed to report what I feel now? I really don't know. And then I thought, well, maybe an answer is we could have some kind of component where the people who live with us could speak to our condition and to how we're actually doing. And that sounded good to me, but then I thought, well, you know what? Some people in my life think I'm perfectly fine when I'm really not perfectly fine. I'm perfectly crappy. So
And the
you know,
differentiation, Melissa, between symptoms and function is so great.
exactly.
There are so many medications that enable the functionality to go up, but that doesn't necessarily eliminate the underlying symptoms and all the fluctuations of all those symptoms.
Yes. And there's just one more thing that I wanted to bring up, which is that I know I've not heard anyone else talk about this on this call, but I have a lateral craniocervical instability. I can't get a CCI diagnosis because of the fact that it is lateral, meaning that it occurs when I turn my neck to the left and to the right, turn my head to the left and to the right. So when I engage in an activity that's extended, that involves turning my head to the left and to the right, I create, that is an opportunity for PEM right there. And also having thoracic outlet. When I engage in activities where I'm using my arms and they're raised, driving for hours, which is also another time when you have to turn your head to the left and to the right, that's another opportunity for PEM. So these two things, I think could or should be considered when designing a study is there a mechanical basis for someone's PEM that we haven't included? And thanks for letting me talk about this.
Thanks, Melissa. Dr. Yellman.
Those were some really interesting points there from Melissa. And I was thinking back to our initial analogy about, say, a broken leg. If you have a broken leg or a broken ankle, and then you're resting and healing on it, and let's just say you never start to weight bear and you never start to progress with that. If you're just laying in bed because you're afraid every time you stand up, you're going to re-break your leg or re-sprain your ankle, right? In some ways, you're not actually testing the function of that leg or that ankle to begin with. So how do you know what your actual threshold is or what your symptoms are? I think when people are trying to avoid PEM, and rightfully so, they may not be understanding what their symptoms are by actually testing out their regular function, right? And just like in the opposite, if you tried to walk on it too fast, you end up back with another injury. If you do the opposite and you don't test the limits at all, you don't try to progress to weight bearing or to healing, you're not necessarily going to be able to determine how your body's responding to those things. And it's hard to report or know what your actual symptoms are, your threshold is at that point. There was an interesting thing you snuck in there that I wasn't necessarily going to comment on, but I think I probably should, is the mechanical basis of post-exertional malaise. And that is an entire can of worms. But we are learning a lot about the neuroanatomical and neurovascular contributions to symptoms in ME/CFS. And I don't think anybody has a complete and full understanding or grasp of it. But I think some of the predominant ideas are that those things can put certain neurological or vascular structures into compromised, irritated, inflammatory conditions or positions, and that can drive much of dysautonomia, that can drive some of the neuroimmune signaling that may then affect how mitochondria behave, et cetera. That can be the lowest hanging fruit or the primary driver of symptoms. And a lot of times when we've tried all kinds of things that work pharmacologically, behaviorally, et cetera, for people, and we're just hitting a wall and nothing progresses, that's when we really have to think about, is there something upstream that is driving those symptoms that these other things can't overcome? But when you successfully determine what that is in any individual, and when you sometimes even fix that, you don't see my observation, what I've heard from everybody is you don't see a full cure of ELS. You can see the symptom burden improve enormously, right? If that's that lowest hanging fruit, the thing that's the one that's always driving that sympathetic overdrive or that dysautonomia or whatever the case may be, pain, et cetera, even intracranial pressure from compression, that can be the primary symptom. That can be the primary thing that tips you into PEM. And so when you get rid of that, now your threshold for PEM is very different. But at some level, you still have that threshold for it, or you still have some underlying dysfunction. It's just that there's been a huge reset in where you are in that point. And so I wanted to touch on that and say, I think the predominant idea among clinicians and researchers right now is that these are incredibly important, often drivers of the illness, but they're not necessarily confluent with the definition of PEM. And then the other topic I wanted to bring up that I think we haven't touched on that's interesting to me is that I think thinking about post-exertional malaise, it's important to consider that the suffering of PEM, in fact, is something that makes PEM self-perpetuating. In other words, you can be in PEM, laying in bed, and you can tell me, Dr. Yellman, I'm not doing anything, and this PEM is just not getting better. I'm resting. And yet at the same time, you're experiencing sensory sensitivities, you're experiencing severe pain, you're experiencing notable orthostatic intolerance, even just sitting up to drink water is making your heart race. And then, so it's not your fault. You're not doing anything, and yet you are metabolically challenging your body. The experience of suffering itself is then perpetuating things. And then I think on top of it all, if you have distress about your PEM, not that everybody doesn't always have some degree of distress, but when you're early in the illness and you have significant distress, is this my new baseline? Am I ever going to come out of this? That is another emotional tax that perpetuates the PEM, right? And so when we talk about the PEM experience being different because you've had the illness for 10 years, maybe there's not that distress component to the self-perpetuation because I've been here before. This stinks, but I know what the cycle is. I'm going to get out of it. I got to wait it out. But I've always worried that the suffering of PEM is actually perpetuating to PEM. And from a clinical aspect, I've seen this happen where people find ways to interrupt their symptoms, to interrupt the experience of the sensory sensitivity so they're not experiencing, to interrupt the experience of the pain, sometimes to literally just find ways to pharmacologically assist themselves to take a 2-day nap. And in fact, sometimes that speeds up the recovery and reduces the intensity of post-exertional malaise in and of itself. And I'd love for us as a community to really think about how PEM is self-perpetuating and how do we recognize those factors and intercede on those as well.
That's a great point. I was having a conversation yesterday and somebody asked me how I am so sometimes nonchalant about it. And the answer to that is that I've been sick for 44 years, since the age of 7. So not a lot of what happens in this condition in my own body is a surprise to me anymore. And that makes a big difference. I feel really deeply for the long COVID community and the people who are recently, diagnosed, because the uncertainty of, is this going to be how I am for the rest of my life, is such a painful, consideration. And, having been this sick for this long, although, I probably wouldn't choose it, gives a perspective of how much better things can get, and the fluctuations that can happen and how things present, at the time that they do. So I just wanted to put that out there for people. Kat.
Oh my goodness. Well, I think Dr. Yellman really got a good bit on the mechanical basis, which I did want to touch on. I've been talking a lot with a few of our others about this, because it is one of the things that sort of led me down the route first to glutamate and out of the TRPs, which are in a way part of the same system. Is that my primary onset was a concussion. And I also, heartily concur with Veronica's point about, needing to know our own bodies, and how that is often something that is not culturally taught or accepted. And I think it's one of the reasons I have been able to make some of the gains I have, is because I came from a background where I had to be so in tuned, being not just an athlete, but working specifically with animals, and you can't really just talk them out of things. You have to be in tune. And that knowledge was very, very helpful. But the fact that I had a concussion and ended up with the same symptoms as people with valley fever or COVID or, EBV or other, at first it made no sense. But then looking into these deeper systems, it all triggers that same dysfunction. And so I think about these, whether it's an ongoing mechanical strain, whether that's an injury or congenital, whether it's viral persistence, bacterial persistence, existing toxins. I think of all of those, removing those is necessary because we need to not be pouring gas on the fire, right? But that point that just because we're not pouring gas on the fire anymore doesn't mean the fire goes out on its own. Sometimes you get lucky. Sometimes that's enough, but often it's not. So often there is still that disease state in place. And I think that's a very, very important point, especially as there are these sort of ongoing arguments about like different triggers and whether or not these are different state, different diseases. And yes, there are going to be, a neck brace is going to be very helpful for somebody who has a mechanical driver and not necessarily going to be helpful for others. But that doesn't mean that the physiological change that happens in PEM is actually so different, right? There is a commonality there. Anyway, on to the next.
Sabrina, and then we'll start reading some of the comments and questions from the chat, from the Q&A.
I think one of the things that I hope that we get a chance to do is like some deep diving into like the immune system. And when I say that, I mean like really being able to go back to like all the infections we've had. Because I think for a long time, medicine has thought infections come, infections go. And for the most part, most people are fine. Occasionally you're going to have this like, small subset of people who are going to have a negative reaction. But like generally, most people get a cold, it's harmless. A flu, it's harmless. This infection, EBV, I mean, most of the population have it, harmless. And we know better now. Recent research has shown us that that's never been true. So for me, it's like we almost have to like completely rethink ME in the scope of that and understand that, and we're seeing this in COVID research, that sometimes it's the COVID infection, but also sometimes it's the COVID infection plus they had EBV, plus they had this and that. So like now we're seeing dementia researchers coming out and saying, actually, infections are a huge player in dementias that we didn't realize. And sometimes the infection was 20 years ago and it took that long. Heart disease, we're seeing that it can take years to unfold and show. We know that there are people with diabetes post infections. I think we need to like put some of the smartest people in a room together at some point. Again, requires money, but do some consensus building and some conversations like we're doing right here, but with cancer researchers, dementia researchers, diabetes researchers, and really go back to, because we started having infections for many of us in the womb. You know, our mothers were told not to get sick, and we were told when we had children not to get sick with infections because there was a danger to the pregnancy. But the reality is a lot of moms still have colds or flus or something hit. They come through, they think everything's fine, but is it fine? Because in COVID research, they saw that the COVID infections in pregnant moms wasn't fine. So I think we have to go all the way back and we have to see that full picture. And I think sometimes patients are being asked to sort of pinpoint the moment, the thing. And I think what really helped me when I went to the States and worked with somebody who was knowledgeable is she kind of explained that could be potentially multiple infections that had piled up on themselves and my system had just given up, as opposed to it was one defining moment. Because I had watched Unrest, and Unrest still remains such a great documentary for people who are new to this, even if some of the pieces are a little dated. But in Unrest, she had this moment where she got sick and she just never got better. And I remember early on thinking like, oh, that's what it's supposed to look like. No, I think that actually, if we really understand ME more completely down the road, we're going to understand that potentially there were infections that we had all the way through and things that were happening from childhood that were potentially setting us up with weak connective tissue or damage to cells or damage to oxygen delivery systems, our lymphatic system not draining properly. All of these things may have been happening slowly until the point where we just hit a tipping point. So I just want us to like really keep that in mind and rethink it, because for me, the infection stuff sometimes goes out the door and we talk about all this other stuff, especially mechanical. And I think they're all connected and looped in and part of it.
And also, Sabrina, what are your thoughts and everybody else on the influence of all the other factors that are also not, looked at in depth, except in isolation? Like we'll they'll do a study on genetics and just look at the genes, right? And not all of the other factors. I hate keep talking about myself, but that's the knowledge that I have very, very deep. As an N of one, I have the constitution, if you will, of my mother, right? While my sister has the constitution of my father. And we were exposed to, many of the same things, same environment, et cetera, et cetera. I am very sick. She is never been sick. Her daughter has a very similar profile to mine, right? So it's like, there is no question that genetics played a role in there, but also my mother with my pregnancy, was very deficient in folate, had a fall with the pregnancy with me, right? Factors that were not present with my sister. And I mean, we know that research has come out on microplastics. We know that a lower immune system has less tolerance for mold environments. And like, there's such a rich set of potential data points that we could be even informally collecting. I don't think that collecting the data itself, right, it is so costly. But that we're not profiling, the individuals when we do research and also in the clinical setting, to go into that deeper understanding of all of the confounding factors that influence the development of the condition. And perhaps the trajectory of it is also being influenced by that.
Yeah, you make some excellent points, and also like where we live in the world and climate impact. And there's a lot of these pieces that we're not even able to start to have conversations about because we can't even do the basic stuff we know we need to do because we're chasing money and trying to, convince people. So I also think that one of my fears sometimes is that data in the right hands, I have no concerns about. When I see smart, knowledgeable, compassionate people trying to observe a group of people to find some commonalities or some correlations that they're then going to take and do a proper study with, I never worry about that because it's like that's data in the right hands. I'm always nervous when I see people who are overly confident and egotistical in the space who feel like their niche is like the answer to ME. Right? And remember, we're multi-system illness. So your niche, super important. We need you come into the conversation, but also listen to that one and that person over there and this person over here. And together we're going to get a bigger picture. So I think that there's like a lot of those confounding factors that like we could track and trace. I guess I'm just always mindful, like it has to be in the right hands because it's the analysis part that scares the out of me, because I've seen so often where people will be like, oh, they're using this medication, it must mean that they're depressed. They're using this, so it must mean this. And it's like, no, actually, we now understand that some of these medications actually have multiple ways in which they work in the body. Is it possible we're responding differently to that medication than maybe what you understand of that medication? So there's that piece. Whenever people say mold caused their ME, I always think in my mind, did it? Or was it a confounding factor in how you ended up getting so sick that you couldn't ignore it anymore? Or it was the thing that tipped you over the edge? So I still think of us, rightly or wrongly, and you can disagree with me, I still think of us as an infection-associated chronic illness because there's still an infectious component, I think, somewhere, if you trace back most of our cases. But I do think all those other things you're talking about are so important. And I think there'll come a day where we'll be able to sit in a room and everybody will have their data and they'll be able to connect those dots so clearly between genetics and the confounding factors and how we're presenting and what medications we're on and what comorbidities hit us. But right now, we're so far from that. It's almost discouraging sometimes when I stop and think about it because research moves so incrementally. And I get it, we want to be safe and we want to be careful, but I also like to break things. Like in my old work, I was a community developer and we weren't afraid to kind of get in there and try some stuff and break some stuff and see what happens, you know? So I have a hard time sometimes in this space because of the slowness of it. And then also being so loyal to my community and recognizing that we have people who are quite literally dying every week. The urgency for me is just the thing we're missing, but it's always linked back to money. If we had money tomorrow, I would get a whole bunch of us in the same room together and we'd be like, okay, who's doing what and what are we going to do? And that's just a little plug that ICANN-CME has grants. And if you guys want to look at getting involved with ICANN-CME grants that we put out once a year, but they're a couple different types, please reach out because even if you're not in Canada, we can find a way to like partner you with Canadian researchers. And you would be doing them such a service by bringing your knowledge into their awareness and doing us such a service as we build capacity in Canada around this illness. So I just want to do a little plug that, you know, you reach out anytime and there is a little bit of money available. It's never enough for the big fancy fun stuff though.
Thank you, Sabrina. All right, we'll start going back and forth with the Q&A. So somebody said, I'm not comfortable with emotional PEM and stress as I experience this as well with joy or looking forward to events I might be able to attend. And then unfortunately, due to emotional PEM out of joy, I am not able to. Is that related to neurotransmitters like dopamine? Whoever.
Just it can take energy to make to experience joy, and it can take energy to experience stress. And if the energy deficit is the issue, they're not at odds with each other at all. And then inflammation can take more energy or change the ability to produce energy, and so you can get all these loops. It's yes and in many, many, many cases.
Anybody else? Okay, we will go to another one. This conversation about research during different stages rings true. I was in the LIFT trial and responded well to whatever I got. Then I slipped down the stairs and went into a crash, which I fear altered the results of the drugs being tested. So how do we account for the situations that happen in the middle of a trial? Any thoughts?
Document. Keep going, but document because it's going to happen to somebody else. It's still data.
But how does that, if there is no provision for incorporating that data into the results, or, you know, rather the analysis before, you know, showing results, then that can show as a fail, you know, the drug did not work for that person while initially they responded, but then they had a fault and their state completely changed.
Yeah. I think that's what I was thinking about, this tool that I mentioned, that we need a very comprehensive like table that is not a single thing or where people can really record that. But that has to be considered from the very beginning of a trial, because I think sometimes it's whoever designs a trial that doesn't think about this firsthand. And it's so important because that's why we cannot go on a fail or exit or a successful trial as a black or white, is how this trial actually worked for people, for each single one of them.
Right. If the reason that they fell down the steps is because they're up and at them, as Dr. Yellman was saying, they're now able to get up and do more and try laundry and maybe carry something and not pay attention. They can be included maybe up to the point that they fell.
Yeah, but sorry to get there, but you see, this is where this idea of inclusion and exclusion against kind of hits me very hard, because if we design a trial and it's so perfect that we are not considering day-to-day life, then that might not apply to day-to-day people once we treat them. Still, the data will be more confusing than if we do a very clean trial. So how do we draw the line there? That for me has always been kind of quite mind-blowing.
Dr. Yellman.
It strikes me, having read a few papers in my day, clinical ones, especially back in sort of rheumatology focused days, we have this assumption that when you provide an intervention in a clinical study, a biologic in rheumatology, right? They monitor like, oh, what is the first few weeks? What is the result at 24 weeks? And then the result at 52 weeks is even better. We have more remission or we have more disease reduction and activity. And we always assume that there's this linear improvement, if there's going to be, or that there's this linear threshold and eventually it starts working after 3 months of the therapy and now you're having that benefit. And I think that if we use that mindset and apply it to the set of circumstances and challenges we've described today, we're going to miss something, because this is not a linear way of measuring data. Again, if you see some improvement and then that causes PEM and there's a dip and we don't know how to detect that and we're not thinking in terms of the variability when measuring outcomes, we're going to fail in the design of these studies. And I would love to talk to somebody way smarter than me when it comes to statistics and study design about how to incorporate these challenges to design better studies to begin with.
I think when Melissa was talking about she's underreported her pain, and she was now questioning all of her bearable everyday at-home data collection on her phone. She doesn't need to question it. She needs to add a note to it in the notes space that says, I've discovered this is what's happening. This is what I've done. And now I'm going to change how I'm tracking because I understand better. Because that's happening to everyone. We're all getting smarter as we talk to each other. Sometimes I didn't even know symptoms were symptoms until I talked to everybody else. Things that I've been living with for years and I never thought to track, but they're quite important. And so that's, I know it's messy to use and look at, and maybe somebody's not going to notice that note, but we certainly don't have the spoons to go back and fix it. But a programmer could go back and add 2 points. If the note says back to March of whatever, I've been underreporting pain, they could add 2 points when they read the export file.
And the chronicity of it also muddies the waters, because we tend to because it's normal for us. Doesn't mean it's fine, but it's normal for us, right? I find that with the general public, like so many people say that they don't have any conditions, they don't have any illness, yet they live with, daily stomach issues, with regular migraines, things that are not debilitating, but they are, symptoms of things. And yet they consider themselves not to have any conditions because they don't have a diagnosis. And I think when we live with something every single day, especially if that particular thing is not flooring us, is not, impeding our current level of function, then it just becomes normalized and it can go unnoticed. Jake, your hand is up.
Yeah, this was something that we were talking about a bit before, but I was just gonna say that like in general, I think that like this doesn't apply to every patient and it's not all the time or you know, but there is I think in general in this patient population, because of neuroinflammation and because of other factors, interoceptive systems are going to be disrupted. And like that, the ability to tell what you're going through within your experiences is going to be disrupted. And my brain's a bit off today, so I wrote some notes in the chat. I was going to say there's also a mechanical basis of interoceptive issues. Like I have mechanical basis stuff. I have CCI, Chiari, tethered cord, and it's made me question enough about like therapy and like which practices that I'd want to actually practice. Like, can I even involve myself in a somatic based practice, or will this slight perturbation of my neck moving slightly and changing my entire autonomic response, like change, what therapy is useful for me. Um, and then also, like, I think that in general, there's just excuse my French, but a shit ton of input that you're dealing with, and naturally, the body is going to try to like shut out some of that potentially, to gain some semblance of peace again. And is this always true? Of course not. I mean, plenty of us are overwhelmed by sensory stuff. We don't necessarily do a really good job at it, but I think there's a likely pathway where this massive amount of sensory input then messes up our interoceptive systems, and then messing with our ability to report accurately on our experiences. And this is why I think like these things that are objective measures, like what the innovation in is trying to do is so important because it's not like we're measuring the state, but like we're measuring things that like you saying my arms always get warm at this time or something like is an objective thing. Like that's not, there's no interoceptive thing that's like determining or messing up this observation. But there can be with things like fatigue, like how well like I'm not saying that, to be clear, I'm not like giving like a mind body approach by any means. I just mean that like your neuroinflammation just changes a lot about perception. And then also this is a strongly ADHD community, which has strong links to interoceptive difficulties and knowing what they're feeling and alexithymia and so on. And like none of those things I think can really be ignored when we're trying to figure out like what are patients going through. And maybe that's even, part of the reason why we have this discrepancy between PESE and PEM, just because the community as a whole is generally speaking quite alexithymic. And anyhow, one other factor I was going to add also is that there is also likely a lot of structural dissociation within these communities because of the incredible amount of trauma that they're going through from this experience. And that structural dissociation will also, again, mess with these observation abilities. But also, I think that like the way in which a lot of the patients in the community dissociate from their experiences is also protective. So like it's not like it has no purpose. It's protective, but it also messes with our ability to tell what we're going through. And like, I don't know, like I feel like you can kind of see that in the distribution of where certain patients are and where certain patients like this group of patients right now, like maybe this is a group of patients that for some reason is able to see patterns within themselves a little bit easier. Like maybe that's why certain people become more scientifically minded within these communities, whatever. My point is just that like these systems are likely disturbed, and that finding objective measures is an incredibly important thing. That's all I got.
Thank you, Jake. A comment from the audience, even can't do anything has variable interpretation. Can you get up to go to the toilet? Can you feed yourself? So, you know, what are the definition of can't do anything, again, being important to understand that we have a common interpretation of what's being asked. Sabrina.
I just wanted to go back to the question about, you know, if you're in an intervention trial and something happens, if at all possible, try to complete the trial and do document. Because there are times where the researcher may not know what to do with that information, may not even care about that information in that moment. But if suddenly the data is really messy or there's things that they can't understand, sometimes they will be curious and they will go back and ask questions and you won't be able to remember, at least I can't, what happened, you know, a month ago, 2 months ago. So like for me, whether they ask for it or not, I typically take extra notes and I try to note like, oh, I had this giant event that I tried to pull off. Wow, that really knocked me for a few weeks. I also always track what season I was in. Spring, summer, or fall, winter, because the seasonality of intervention, I think, like I try to tell researchers to keep an intervention in the either spring, summer, or fall, winter to get a more accurate result for the N of 1 kind of effect. So like some of those things, like if you're tracking them, you can go back if there's curiosity later, or if the trial fails, you can go back and ask other people like, hey, were any of you seeing things or have reasons? And those conversations are important and they do matter. And curious researchers will come back and ask questions, and those who don't, they just don't know that there's more data there that they don't know you're interested. So like reach out and say, hey, I know why I failed, but like if you can, try to stick with the trial as best you can, because the reality is, to other people's points, you know, that's normal. It's not linear and there are up and downs. And so if you can, try to complete the trial.
Thank you. Another comment from the audience. My PEM after physical exertion is felt from the neck down as far as PEM symptoms. In the last few years, my PEM after mental and emotional exertion has been from the neck up in my brain organ. These new experiences of PEM in the brain has been scary because I feel this new type of PEM is telling me I'm getting worse. Any comments to that effect?
I think so if somebody has a cluster of symptoms that tends to be around one or more body parts, and then that cluster of symptoms changes to other body parts, that's a change and spreading. And so is that word, do you use the word worse? Do you use the word more spread out? They're things that they're more areas of the body having something going on. And I suppose it could be possible one was on a healing trajectory, and because of that there were certain things going out there, and so you have feelings across different parts of the body. Equally, you could be on a decrement path of inflammation or what have you. But those differences I think are key. And then is to go back to the questions about the studies, the idea of normalizing to self, I think, ends up being really, really, really helpful. And so somebody may have a high pain tolerance and call their thing a 7, and their thing that's a 2, somebody else may call a 10. And so those numbers may be really hard to go, but the person with a 2 that tends to mark it as a 10, then if they're saying they have a 5 instead of a 10, that's a meaningful difference for them. And so I think those are really helpful. These Likert scales where you take a raw number, keep the raw number, but then turn that into a extreme for you, an all or nothing, and where do you put yourself?
Yeah, somebody else said perhaps an idea is to develop questions in a manner similar to the eye doctor choices of which is better can be may be helpful. Dr. Yellman.
To the idea of different phenotypes of PEM, I just want to throw a monkey wrench into the thought process here, which is essentially, if we think of PEM as a altered physiological state, impaired physiological state, is that a state where you are more susceptible to perpetuation of certain symptoms that have already gotten rolling? And that's sort of conceptually what I think of it as. And so when somebody says, I have these PEM symptoms with my cognitive exertion or these symptoms with my physical exertion, are they experiencing PEM and in that altered susceptible state having a perpetuation of, say, maybe the neuroinflammatory response that kicked off the PEM to begin with, and now that is a prominent and perpetuated symptom, and so your phenotype is PEM plus that neuroinflammation, or alternatively your phenotype is PEM plus that cellular, skeletal muscle exhaustion that occurred for whatever reason, right? Is that what's actually happening in different PEM states, or are they truly different, or just a susceptibility to, whatever symptom kind of kicked it off in the first place being the most prominent upfront symptom? And especially when you get further into your illness, and maybe you've learned to differentiate between those, maybe you've actually paced or been on some drugs that help separate those things out so that when you have a flare of neuroinflammation, it doesn't necessarily coincide with a flare of that skeletal muscle metabolic issue. Maybe that's what we're seeing when we start to notice that. So just something to think about. I'm not committed to any answer one way or the other, but if it wasn't complicated enough, I might have just made it more complicated.
I like that point, getting me to think about, again, that assessment of what are the underlying interventions that one is under in order to differentiate what has an effect and what not. Like one of my medications is tramadol, and before having the PEM formula, I know that it did help with the musculoskeletal symptoms of PEM, right? So is having that under, therapy underneath masking what I could be getting, with when I do physical activity and not having that muscle soreness as pronounced. Yeah, that's a great point.
Well, and specifically in the case you just mentioned, that example, that is a therapy that people can argue, but I don't know that necessarily is targeting a core feature of ME/CFS, but it is a major symptom blocker. So it's interrupting that interpretation of your symptoms.
Yeah, absolutely. Yeah, that's a great point and something to really think about. Yeah. Veronica.
Thank you. Just one, probably this is not a full reply to Jake, but he made me think about our conversation that we were having the other day about how we have realized that so many of the patients, at least with long COVID, they've been trying so many different pharmaceutical interventions or supplements just because they read about it, and how lightly we take this. And it's very understandable that people keep on trying, but after all, these are also insults to the body. Any therapy has pros and cons. And I think, I do understand why people do it, but at the same time, we have to think how to communicate that they have to be very careful about it. Because, for example, a very fine example I had this week on a discussion is even things like piperine, for example, if it is in a concentrated manner that you're taking it in tablets, that could actually affect the way you metabolize other treatments. And many medical doctors never even mention that, probably because they are not even aware of the pharmacological points. But I do understand, because at the same time, from what Jake was saying, being a chronic patient is a lot of effort. It's an effort not only on your physical needs, but on everything that you have to go through to kind of just keep up. So how can we really facilitate that kind of agenda keeping and that, writing of the symptoms, when is another thing that we are asking patients to do, and it's not easy. So I do feel so much, as for patients, because we're asking them to do too much without really giving them enough guidance, like to that specific point of even what they are eating on a day-to-day can really affect the treatments, not only their health.
Yeah, really good point. We have another question in the chat, and maybe you can also speak to what Veronica just said, Dr. Yellman. So the question for Dr. Yellman, I am an N of 1. From my tracking, I find that gabapentin dramatically lowers my HRV. In the literature, it is supposed to increase deep sleep. In my tracking, it increased deep sleep by a minimal amount. Generally, it increased my total sleep to an amount that was not significant. I stopped it, but wondered if you have thoughts on the mechanism.
I just want to make sure I'm hearing. So the idea there is that gabapentin is improving a little bit of the deep sleep, but not the total amount of sleep, and yet the heart rate variability is actually worse, not better with its use.
Correct.
Yeah. I mean, it's one of those clinical scenarios that I would want to spend 20 minutes with a patient on, trying to actually figure out the answer there. I'm not sure there's a single specific answer. I think it really is a question of understanding the entire environmental milieu in that case, because gabapentin, on a very basic level, has a lot of physiological functions. It's used for all kinds of different indications in medicine in general. It's generally thought to calm down neurological signaling, whether that's neuropathic pain or to kind of relax over signaling that might be contributing to sleep disruption, et cetera. But these drugs aren't always perfect in their mechanisms. We can think of it as like, oh, this is a sleep drug, but is that sleep actually more restorative? Is it impairing some other processes during sleep that actually we fail to recognize but are really important to recovery, especially on a metabolic or neuroinflammatory level? There's so many details in here that I think those kind of questions are really hard to answer, and they end up becoming N of 1 questions more than generalized gabapentin does this or does that.
Thank you. Dr. Haughton?
Yeah, just on some of the layering of language, it may be useful as people are thinking about context to, as they describe something, to describe what layer they're talking about. So for instance, the World Health Organization stratifies impact as disease, impairment, disability, handicap. So a disease might be problem laying down the bone or breaking a leg or something because the bone wasn't laid down. And so that would be that localized process at the cellular level. And then impairment is the impact on the organ system. So let's say you had loss of bone and then you broke your leg. That would be, you have a broken leg, that's the organ. Or a kidney got damaged, that's the issue. Or the brain isn't working as well. And then the disability is the impact on the individual. So with a broken leg, as an individual, I can't walk. That's what is going on with me. And then the handicap is the environmental impact. So if I live in a first floor apartment, I can go to work because I can wheel in and out of a wheelchair. Let's say I can't put any weight on my leg, but if I live at a third floor, I'm at home. I can't get out because it's a walk up, and I used to be able to walk up and I couldn't, or I can't at this point. So that disease, impairment, disability, handicap can help to speak about which area you're talking about. And then I think in the conditions that we're describing, we have layers of infectious, vascular, metabolic, and immunologic, and to sort of think through those. Oh, it's inflaming, so the immunology is changing, but it's inflaming because I have an infection, the COVID virus, it's the Epstein-Barr virus, or it's inflaming because my vessels aren't working very well and not letting blood through, and then the metabolic pieces can change how much energy is available or inflammation. And so that idea of infectious, vascular, metabolic, and immunologic end up being a layering as well. And within that, there's a whole bunch of nuance that you can keep track of while you're talking about or thinking about things.
All right, we are over 2 hours into this conversation. Some of the comments left are, some of the points that we've already discussed, but we will save the chat, the Q&A, if there's anything else to post with the recording. And we can always continue having these conversations, right? It's not a one-time thing. We can continue iterating and, patients, researchers, clinicians helping each other to be able to, for all of us to do a better job at what we do and for the benefit of, the patient community that is suffering. And I'll echo Sabrina's call. If you have money, there is a great need to fund all of this work that is severely underfunded. Accelerating it, being agile, and including the patients, it's a critical aspect of doing this work. So just wanted to open it to the panelists if you have any last comments, last thoughts that you'd like to share before we go.
I think
Ellie.
3 days, for some people, PEM starts 3 days later. People have no consciousness left of 3 days prior, and that's a really difficult thing. And they'll still say that it came out of nowhere. It takes a lot of encouragement from the clinicians and from peers, from articles, to remind people that if they do activity to note it, if they're likely to forget it. That's it.
Thank you. I'll be honest, 3-day PEM, if it does happen for me, definitely goes unnoticed unless the activity was really, really major. Yeah. Notice in the sense that I'm not related. I'm calling it, a bad
Out of
day.
nowhere. Yeah.
Yes, out of nowhere, rather than relating it to what happened 3 days ago. I'm lucky if I remember what I had for breakfast when I have breakfast.
Right. And if it goes, whatever the activity is, if it went successful, then in your mind, you can do that and you're allowed to do that.
Absolutely.
If you never make the connection, you will do it again.
Absolutely. The
So
last
maybe
time I remember
years.
something like that happening was I hosted a big activity, and it was either 2 or 3 days later when I started to feel the effect, but the activity was really significant, to be able to notice, and the PEM was much more severe than regular. So that's another challenge that we need to be looking at and asking questions about, for sure.
My final thoughts are just thank you for doing this. I think this is so important. I think these conversations always, they roll around in my head for months. So I know what they do for me. I can only imagine that other people on the panel feel the same. And hopefully the audience gets something meaningful and important out of it, or at least feel validated that we see them and we understand and we're like really fighting hard here. We keep a lot of that stuff, I think, behind closed doors because we know that like you got to throw 100 pieces of spaghetti at the wall for one to stick. So we don't talk about all the things we're trying and doing sometimes, but like, please trust that like everybody here and a whole bunch of people that aren't here are really trying hard to come up with innovative ideas and trying to collaborate to be able to get better answers. And it starts from conversations like these. So thank you guys at Renegade Research for this.
Thank you. This clinical perspective was Dr. Yellman's idea, so it's all his fault.
Thank you, Dr. Yellman.
Wonderful.
And our next event is about sleep and breathing dysfunction. And a lot of people do say that if their sleep is off, their PEM is going to happen either more frequently or they can't get out of it. So I hope you can join us on July 31st. It's a Friday, right?
Yes, and the perspective that
At
you do
noon.
not have to be diagnosed with sleep apnea to have, that airway obstruction that causes that sleep dysfunction. That can be really significant. So
He talks a lot about not being refreshed when you wake up. And I think that is one of the key PEM symptoms for me is when you wake up and you feel worse than when you went to bed, that's a sign I've overdone it. And it's such a mind
And a
for the
vicious
statement.
cycle, because if you get a little less sleep, your threshold for PEM is less, and then you're more likely to be in PAM, and then your sleep is worse than it was, and yeah, downhill from there.
PEM
And-
is self-perpetuating.
Yeah. Any other thoughts?
Yeah, thank you. I'll just like to join into Sabrina's comments of this idea that I've been trying to push. That thank you, Renegade Research, for this session, and that how much we really need to try. I know it's very hard because different groups are kind of in conflicting thoughts, but I think we're in an overall picture. We're so few around the world that it will be lovely. We could really try to join and get some standardized thoughts, at least the main ones, because we need to do so much, but we really need everybody from all over the place. And just another thought that came to me now about the money. I know it sounds horrendous, but there's been a lot of famous people lately that they are showing signs of what I could probably think might be long COVID. And probably we could invite them, because I know they are probably not accepting the fact because it's not good for their fame. But if we can get to them in a kind of quieter place, because that could help them and that could help everybody, because many of them do have the money that could, not probably one single person, but many of them probably that could sum up.
Thank you. All right, guys. Thank you, everyone. And hopefully we'll see you all on the 31st. Thank you very much. Bye-bye.